Hi, in today's video, I'll be talking about hyperglycemic crisis. Diabetic ketoacidosis and hyperglycemic hyperosmolar state are two more serious acute and life-threatening hyperglycemic emergencies in individuals with type 1 diabetes and type 2 diabetes. There has been an increase in the number of admissions to the hospital due to diabetic ketoacidosis and hyperglycemic hyperosmolar state in the past decade. Both of these conditions are associated with increased morbidity, mortality, and length of stay. While the diabetic ketoacidosis is more common in younger people with type 1 diabetes, hyperglycemic hyperosmolar state is more common in the middle-aged and older adults with type 2 diabetes. Most common precipitating factors for diabetic ketoacidosis include infections such as urinary tract infection, pneumonia, omission or insufficient use of insulin, non-compliance with medications, and physiological stress. In the recent years, there has been an increased instance of euglycemic diabetic ketoacidosis secondary to SGLT2 inhibitor use. Euglycemic DKA is defined as plasma glucose less than 200 milligrams per deciliter in the presence of ketosis and metabolic acidosis. Pathogenesis of hypoglycemic crisis. The key difference between diabetic ketoacidosis and hyperglycemic hyperosmolar state is a degree of insulin deficiency. Diabetic ketoacidosis is characterized by severe insulin deficiency and increase in counter-regulatory hormones such as glucagon, cortisol, and epinephrine. In hyperglycemic hyperosmolar state, there is less insulin deficiency to prevent ketogenesis, but not enough insulin to prevent hyperglycemia. So an absolute insulin deficiency with increased counter-regulatory hormones will cause decreased glucose utilization, resulting in increased lipolysis, causing increased free fatty acids, which can then be converted to ketones in the liver, causing ketoacidosis. There's also increased glycogenolysis and hepatic gluconeogenesis in the liver that contribute to the hyperglycemia. When there's a relative insulin deficiency, there's decreased glucose utilization in the peripheral tissues, resulting in hyperglycemia. There's also increased gluconeogenesis in the liver, causing hyperglycemia, which causes osmotic diuresis, resulting in volume depletion, which in turn causes hyperosmolarity. Diagnostic criteria for diabetic ketoacidosis and hyperglycemic hyperosmolar state. The diagnosis of DKA is based on the three criteria, and the three components must be present to make this diagnosis. D criteria stands for diabetes or hyperglycemia, which is defined as blood glucose greater than 200 milligrams per deciliter or history of diabetes irrespective of the presenting glucose value. K criteria stands for ketosis, which is defined by beta hydroxybutyrate greater than 3 millimoles per liter or urine ketones greater than 2+. A criteria stands for metabolic acidosis, which is defined as pH less than 7.3 with or without serum bicarbonate less than 18 millimoles per liter. Anionic gap was removed from the diagnostic criteria. Diagnostic criteria for hyperglycemic hyperosmolar state is based on the four criteria, and all four components must be present to make the diagnosis. Hypoglycemia is defined as plasma glucose greater than 600 milligrams per deciliter. Hyperosmolarity is defined as calculated effective serum osmolality greater than 300 milliosmolar per kg or total serum osmolality greater than 320 milliosmolar per kg. Absence of ketosis is defined by beta hydroxybutyrate level less than 3 millimoles per liter or urine ketone less than 2+. Absence of acidosis is defined by pH greater than 7.3 and bicarbonate concentration greater than 15 millimoles per liter. Diabetic ketoacidosis can also be classified as mild, moderate, or severe based on the magnitude of metabolic acidosis, ketone levels, and presence of altered mental status. Mild diabetic ketoacidosis is defined by glucose greater than 200 milligrams per deciliter, beta hydroxybutyrate between 3 to 6 millimoles per liter, pH greater than 7.25 or less than 7.3, or bicarbonate between 15 to 18 millimoles per liter. Mental status is usually alert. Moderate diabetic ketoacidosis is defined as glucose greater than 200 milligrams per deciliter, beta hydroxybutyrate between 3 to 6 millimoles per liter, pH between 7 to 7.25, bicarbonate between 10 to 15 millimoles per liter. They are usually alert or drowsy in terms of mental status. Severe diabetic ketoacidosis is defined as glucose greater than 200 milligrams per deciliter, beta hydroxybutyrate greater than 6 millimoles per liter, pH of less than 7, serum bicarbonate less than 10 millimoles per liter, and they usually have change in mental status in the form of stupor or coma. A key diagnostic feature in diabetic ketoacidosis is elevation of ketones in the blood. Ketones such as acetoacetic acid and beta-hydroxybutyrate are elevated. For the diagnosis and monitoring of the response to treatment, recommendation is to measure venous or capillary beta-hydroxybutyrate, which is the main keto acid in DKA. Blood levels greater than 3 millimoles per liter correlate with greater than 90% sensitivity and specificity for the diagnosis of DKA. Other conditions that can cause elevated ketones are starvation ketosis, alcoholic ketoacidosis, and ketosis secondary to hyperemesis gravidarum. Most people with diabetic ketoacidosis present with high anionic gap metabolic acidosis. However, mixed acid-base disorders are present in about 1/3 of those presenting with DKA. They include metabolic alkalosis secondary to volume contraction and compensatory respiratory alkalosis caused by hyperventilation. Clinical presentation of diabetic ketoacidosis and hyperglycemic hyperosmolar state. Diabetic ketoacidosis develops over hours to days, whereas hyperglycemic hyperosmolar state develops over days to a week. Polyuria, polydipsia, and dehydration are common in both the conditions. Nausea, vomiting, and abdominal pain are more common in patients with diabetic ketoacidosis and less common with hyperglycemic hyperosmolar state. The respiratory compensation for metabolic acidosis found in DKA is manifested in the form of Kussmaul's breathing. Changes in cognitive state are usually seen in patients with hyperglycemic hyperosmolar state, but also seen in patients with severe DKA. Treatment of diabetic ketoacidosis and hyperglycemic hyperosmolar state includes administration of intravenous fluids, insulin, and potassium. Intravenous fluids. Isotonic saline or balanced crystallite solutions such as lactate ringer is the initial choice of fluids. IV fluids are given at a rate of 500 to 1000 ml per hour in the first 2 to 4 hours. Dextrose 5% or 10% is added to the normal saline or lactate ringer when blood glucose reaches less than 250 milligrams per deciliter. In euglycemic DKA, where the blood glucose is less than 200 milligrams per deciliter, 5% or 10% dextrose needs to be started along with normal saline at the start of insulin treatment. Initial fluid resuscitation restores the effective circulating intravascular volume, improves renal perfusion, and decreases the plasma glucose level and osmolality. Older adults, individuals with heart failure and end-stage kidney disease should be treated cautiously with small boluses. Insulin. For mild DKA, it is now recommended to use rapid-acting insulin subcutaneous at a dose of 0.1 units per kg every 1 hour or 0.2 units per kg every 2 hours. For moderate to severe DKA, it is recommended to use short-acting insulin intravenously at a dose of 0.1 units per kg, either in the form of fixed-rate insulin infusion or a nurse-driven insulin infusion protocol at a variable rate. In people with hyperglycemic hyperosmolar state, fixed-rate insulin infusion is given at a rate of 0.05 units per kg per hour. When the glucose level reaches to less than 250 milligrams per deciliter, one should reduce the insulin rate to 0.05 units per kg per hour intravenously. In people with diabetic ketoacidosis, keep glucose between 150 to 200 milligrams per deciliter until resolution. In patients with hyperglycemic hyperosmolar state, target blood glucose is between 200 to 250 milligrams per deciliter until resolution. Potassium replacement. Establish adequate renal function by checking urine output to be at least 0.5 ml per kg per hour. If the serum potassium is less than 3.5 millimoles per liter, replace 10 to 20 millimoles per hour until potassium level is greater than 3.5. If the potassium level is between 3.5 to 5 millimoles per liter, give 10 to 20 millimoles in each liter of IV fluid to keep serum potassium between 4 to 5 millimoles per liter. If the potassium is greater than 5 millimoles per liter, do not give any potassium and start insulin. One needs to check blood glucose every 1 to 2 hours while the patient is on insulin, and check electrolytes, renal functions, venous pH, and osmolality every 2 to 4 hours. Glycemic. In patients with DKA, it takes around 4 to 8 hours approximately for the plasma glucose to come down to below 250 milligrams per deciliter while on insulin, whereas in patients with hyperglycemic hyperosmolar, it takes around 8 to 10 hours for the plasma glucose to reach less than 250 milligrams per deciliter. One should be cautious and not decrease the blood glucose by more than 90 80 to 120 milligrams per deciliter per hour to avoid cerebral edema. One should also avoid decreasing the osmolality no greater than 3 to 8 milliosmol per kg per hour to prevent cerebral edema. Correction in sodium level should not exceed more than 10 millimoles per liter in a 24-hour period. Routine bicarbonate administration is not recommended. Intravenous fluid resuscitation and insulin administration are usually sufficient to resolve the metabolic acidosis in DKA. However, bicarbonate administration should be considered if acidosis is severe with pH of less than 7. Phosphate should not be given unless serum phosphate level is less than 1 millimoles per liter and associated with muscle weakness and respiratory compromise. Transition to maintenance insulin therapy. Patients with diabetic ketoacidosis will eventually need transition from intravenous insulin to subcutaneous insulin. It is important to allow an overlap of 1 to 2 hours between the administration of subcutaneous insulin and discontinuation of intravenous insulin. To transition from intravenous to subcutaneous insulin therapy, an estimation of total daily insulin requirement is needed. This total daily dose of insulin can be calculated using weight, pre-admission insulin regimen, or hourly intravenous insulin requirement. Weight-based estimate. Insulin can be given in a dose of 0.5 units per kg per day, or dose can be reduced to 0.3 units per kg per day for those with risk factors for hypoglycemia. Pre-admission insulin requirement. Consider total daily dose of insulin based on the dose prescribed as an outpatient prior to the admission. Hourly intravenous insulin requirement. Total daily dose of insulin can be calculated from the total amount of intravenous insulin the patient received in the prior 12 to 24 hours. Ensure that the subcutaneous insulin regimen provides 24 coverage. It can be given in the form of basal and rapid-acting insulin. Begin with 50% of total daily dose to be given as basal insulin and the remaining 50% to be divided in 3 mealtime doses with rapid-acting insulin. Do not initiate or continue SGLT2 inhibitor treatment during hospitalization. Non-insulin agents are not recommended in patients with type 1 diabetes. Complications. Hypoglycemia. It is a common complication encountered during the treatment of DKA and hyperglycemic hyperosmolar state. Hypoglycemia is defined as blood glucose less than 70 milligrams per deciliter, whereas a severe hypoglycemia is defined as blood glucose less than 40 milligrams per deciliter. One can avoid hypoglycemia by frequent blood glucose monitoring every 1 to 2 hours while on insulin therapy. When the blood glucose levels are less than 250 milligrams per deciliter, it is advised to reduce the insulin infusion to 0.05 units per kg per hour and add dextrose 5% to normal saline or Ringer's lactate. Hypokalemia. It's a common complication owing to intracellular shift of potassium during insulin infusion. Mild hypokalemia is defined as less than 3.5 millimoles per liter, and severe hypokalemia is defined as potassium less than 2.5 millimoles per liter. Severe hypokalemia is associated with increased inpatient mortality. One can avoid hypokalemia by monitoring potassium levels every 4 hours during insulin treatment. Thrombosis. Both diabetic ketoacidosis and hyperglycemic hyperosmolar state are associated with prothrombotic state. Prophylactic dose of low molecular weight heparin should be used to prevent thrombosis. Cerebral edema. In patients with diabetic ketoacidosis and hyperglycemic hyperosmolar state, rapid shift in osmolarity and rapid decrease in blood glucose levels can be associated with cerebral edema. In order to prevent cerebral edema, one should avoid rapid correction of osmolality and hyperglycemia. Mannitol infusion and mechanical ventilation are suggested treatment for cerebral edema. Osmotic demyelination syndrome, previously known as central pontine myelonolysis. Osmotic demyelination syndrome can occur with rapid correction of hyponatremia. One can avoid this condition by preventing rapid correction of hyponatremia. Thank you.